In this particular section, we will be discussing extensively on capnography. Why I choose this topic to discuss separately is the fact that this topic has grown leaps and bounds in the last 1 decade. At the same time, this has become one of the mandatory apparatus in the ICU as well as in the emergency. And lot of new advances and many different waveforms are coming in the capnography section, so that it really becomes one of the hotspots for the exams as well, and it mandates your understanding about the capnography also. So let us understand what are the things you are going to look out in the capnography. At the same time, what do you mean by capnography? Remember, first of all, capnography means you are going to detect carbon dioxide. That CO2 detection is what we are going to refer to as capnography. So what are the things that are measured under capnography? First one is the waveforms. The waveform capnography. The waveforms are the ones that are measured. So you can see the waves, isn't it, in the capnography, any capnography chart if you see. So that waveforms is what we call waveform capnography. Using the waves, we can understand certain aspects of patient's biochemical properties. And number two is the end tidal carbon dioxide. Remember, this is a numerical value. Waveform is something like a graphical representation, but this end tidal carbon dioxide is the maximum CO2 peak that is reached in the capnography mission. I mean, with or without the waveform. So that is what we refer to as EtCO2. And the third one is the carbon dioxide trend. That's what we're going to look out for. So what do you mean by trend? So for example, if you have the changes in the waveform happening over a long period of time, maybe say half an hour or 45 minutes, it's changing very slowly. In this condition, it's really difficult to see the difference between 3-4 waveforms and tell that the capnography waveforms are changing. So you have to see the trend. So when you see the trend, what do you mean by trend? They are compressed waveforms. So they will compress all the waveforms and they will give a sort of a trend over a period of time. So for example, let me draw you two waveforms now. So probably these are the three waveforms. Even though I have intentionally drawn to show that they are decreasing in their size, but in real time, it may not appear as if they are decreasing. They might look almost the same. So when you see the trend, so they will compress all the waveforms together. So that since they are getting compressed over a period of time, you can see that the trend is actually towards the decreasing side. So this is the advantage of a CO2 trend. So we'll be discussing in some time what do you mean by CO2 trend and how it helps in understanding the capnography. So these are the three principal things that we're going to look out for whenever we are thinking about a capnography. Now let us move on to the phases of capnography waveform, because this is based on simple physiology only, nothing much. So for that, let me tell you there are 5 phases in capnography, but modern textbooks give only 4 phases. But let us assume there are 5 phases. First one, the point A to B is referred to as phase number 1, and from point B to C is referred to as phase number 2, and point C to D is referred to as phase number 3. Please do note that these 3 phases happen during expiration. Clear? So these 3 phases, that is phase 1, 2 and 3, happen during expiration. At the same time, you have phase 4, that is from point D to E, and phase 5 from point E to A. Clear? So these 2 phases are present during inspiration. Remember this, here the inspiration is there. Again, it's a continuation of that E to A point only, so I'm not going to draw that. So 1, 2, 3 phases are happening during expiration, and 4 and 5 are happening during inspiration. Clear? So, and you also have to note the fact that expiration usually will be containing CO2 rich air, which means the concentration of CO2 will be much higher compared to that of the inhaled gas. And inspiration will be containing CO2 poor air, which means they will not contain carbon dioxide. Very, very negligible amounts, maybe 0.03% in the atmospheric air. We saw that already in the physiology. But anyway, so this is what you have to know in the first place. So that is the reason why whenever the inspiration starts, you can see the CO2 levels immediately drop, and it's in the 0 mark only in the baseline till you reach the expiration. Okay, this is understandable because inhaled gases contain no carbon dioxide. That's why the graph immediately falls after expiration and follows a flat line. But why during the initial phase, that is from A to B, that is during the phase 1, still the carbon dioxide is in the flat line, which means carbon dioxide is not rising even though the expiration is happening. Further, you have to understand a very simple physiology that whenever you exhale first, the first gas that comes out during exhalation is the dead space air. The dead space air or dead space gas is not going to take part in the gas exchange at all. So they will come just like that, which means the inhaled gas that is present in the dead space will be the first to come out during exhalation, which will not again have any carbon dioxide, which means it's still CO2 poor gas only, like the characteristics of inhaled gas only will be there. So let us see with some basic examples. I have drawn some alveoli here. So you can see in the first example, in this example, remember the pink color always means the CO2 detector. So let me tell you how they detect the CO2, but right now understand that the pink color in this is the CO2 detector. So what happens at the end of inspiration? So what is happening at the end of inspiration is the fact that inspiration means CO2 poor air only is coming inside the respiratory tract, which means this is a CO2 poor air only. Green means CO2 poor air in this example. And blue means you contain a little bit more amount of CO2. That's it. So since you are inhaling, even at the end of inspiration, you will be still inhaling only. You will be inhaling the CO2 poor air only. The CO2 detector will be detecting that there is very negligible or no amount of CO2, the gas that is passing across the detector. So that is the reason why during end inspiration also, so maybe I can draw at this point in this graph, you can see the marker I am showing. At this point still it is a flat line only. But when you come to expiration, what happens? So let me draw the dead space first. Let us assume these are the dead space. So when you come to the dead space, you can see that this inspired air is actually accumulated in the dead space. Since the alveoli like it's a gas exchanging area, they absorb this O2 and they release this CO2. Clear? So they will absorb this O2 and they're going to release this CO2 into the alveoli. But the dead space will not be taking part in the gas exchange, which means they can't transport oxygen and carbon dioxide between blood and themselves. So they will be containing only the inspired air that is still present in the dead space. So when you are exhaling, the first gas to come out during exhalation is the same inhaled gas that is present in the dead space as dead space air without having any gas exchange with them. So that is the reason why the dead space air that is getting exhaled during the initial part of expiration will be CO2 poor only. And that is also one of the main reasons why this phase 1 is showing a flat line. You don't have any carbon dioxide at all. Clear? Because I can write this phase 1, you are eliminating dead space air. That's all. Fine. So now what happens in phase 2? During phase 2 and phase 3, you know that the alveolar air comes out along with the dead space air. Initially the mixing of alveolar and dead space air will happen. Later on your alveolar air alone will start coming. So that is the reason why you can see in phase 2 and 3, it's the alveolar air that is coming out. So since the alveolar air contains a little bit more carbon dioxide proportionately compared to the inhaled gas, that's why the CO2 is rising and forming a peak. For example, I can write this is phase 1 here, this is phase 2 here, beginning of phase 2, and during end expiration you will reach the late stage of phase 2 and phase 3, which means they will reach the alveolar plateau. Remember, obviously they will reach a plateau. You cannot contain infinite amount of carbon dioxide anyways. So I can write this phase 3 is nothing but alveolar plateau. Clear? Cool. That's all. So now you can see during inspiration, once again, whatever may be the phase of inspiration, you are only inhaling the CO2 poor air. So they will form the phase 4 and phase 5. And I want to tell one important point, that remember this phase 4 and phase 5 is no longer called as phase 4 and phase 5. Instead they are called as simply phase 0 by many textbooks. Even though we call it as phase 4, but some don't get confused when you are studying a different textbook, because many times the US textbooks give us phase 4 and phase 5, the UK textbooks and European textbooks give us phase 0. So that doesn't make any difference at all, but the concept is the same. So even if you study as phase 0, don't get confused. So these are nothing but phase 0. So I can write whatever may be the phase of inspiration, it's always phase 0, or I can write it as phase 4 and phase phi also. This is also phase 0. Whatever may be the phase of inspiration, I don't have any problem. Clear? So this is how the graph is formed. So now let us understand some other things also, because there are something else you have to understand with this. That is the PaCO2 EtCO2 gradient. Let us see what is that. So let me draw a line depicting the partial pressure of arterial carbon dioxide. So I will write it as P small a CO2. Small a means it is arterial carbon dioxide. Then I'll be putting another line here depicting the N-tidal carbon dioxide. Clear? So this is the EtCO2, N-tidal carbon dioxide. So you can see one obvious fact that there is always a gap between partial pressure of arterial carbon dioxide and N-tidal carbon dioxide. Usually the gap will be 3 to 5 millimeters of mercury. You know very well the PaCO2 normal value is somewhere around 36 to 44, or some books tell 35 to 45 millimeters of mercury. But remember, EtCO2, the same textbook will give 35 to 45, 36 to 44, but I don't believe it can be that way because it's always lesser than the arterial carbon dioxide. So then I feel the normal EtCO2 must be somewhere around 32 to 40 or 30 to 42, so somewhere around that range. So it cannot be 35 to 45, it will be 32 to 42. So that's the usual EtCO2 range. Clear? So it's almost similar to that of the PaCO2, but still it must be lesser. Why? Is there any rule that it has to be lesser? Yes, there is a rule. Even with physiological limits, the EtCO2 must be lower than the PaCO2 only. Why? Because I told you there are some alveoli in your lungs that are not perfused properly. The gap is because certain alveoli are not perfused and you are creating a dead space. So how to understand that? Now let me draw two alveoli in this example. So I am drawing a couple of alveoli here, perfused by two different vessels. Let us see why I am drawing this. So both are going to form capillaries, definitely, and both will be turning into pulmonary veins as well. Clear? Both will be turning into pulmonary veins also. So let us assume this particular capillary is occluded. This particular blood vessel is not working properly. So this can happen physiologically itself. This is not something pathological. For example, I told you in the normal lung itself, we have VQ mismatches in different zones. That's what we refer to as a vascular waterfall model. In the zones of West, in the zone number 1, that's in the apical zone, we naturally saw that the perfusion is very, very poor. So you can imagine this alveoli like a zone 1 alveoli. So where there is no perfusion at all, which means the ventilation will be happening for namesake. But remember, the effective ventilation can happen only if the carbon dioxide is released into this alveoli. If you don't have perfusion properly, then how you can get an effective ventilation? So you can't get an effective ventilation, but still air will be coming in and going out, which means the same. It's behaving like a dead space. You have the gas that is coming down, that the inspired gas, but they won't have any gas exchange at all because of poor perfusion, and the same inspired gas is going to go out. So it's like a dead space only. So I can tell that this alveoli behaves like a dead space. So that's why this is what we refer to as a alveolar dead space. On the other hand, the carbon dioxide movement will be very good in this alveoli because it's nicely perfused. So the carbon dioxide will be going out from this particular alveoli only. So what you are essentially seeing here is you are having a lot of this alveolar dead space physiologically itself to some extent. So that is the reason why you have this PaCO2 and EtCO2 gradient, which means the carbon dioxide that is present in the blood is not getting distributed into all the alveoli equally. Some alveoli are receiving carbon dioxide, some alveoli are not actually. So that is the reason why there is a gap. And that gap, I can shade it and I can tell that this gap is due to only one reason, that is alveolar dead space. So I can write this gap is due to alveolar dead space physiologically itself. Pathological conditions where the alveolar dead space increases, obviously, like this gap also will expand. So that's the next question. So when the gap will expand, which means when the gap will be the PaCO2 and the EtCO2 gap will keep increasing. Very simple. So now I can tell whenever the alveolar dead space is increasing, I can tell the gap also will expand. When the alveolar dead space will increase, let us go back to the original respiratory failure equation. I told you in VQ mismatch, the perfusion reduces, the ratio becomes more than 1. It can even reach infinity in a massive pulmonary embolism, but ratio becomes more than 1. If it becomes more than 1, this is what we refer to as an expansion of alveolar dead space. So which means if my perfusion decreases, my alveolar dead space increases, that will increase my PaCO2, EtCO2 gradient as well. So examples, very simple. What are the conditions that reduce the perfusion? Pulmonary embolism, cardiogenic shock and cardiac failure, and you have cardiac arrest, and finally increased intra-alveolar pressure. What do you mean by increased intra-alveolar pressure? Whenever you increase the PEEP or very high level of positive pressure ventilation. These are the classic examples. You know, when you give a high PEEP, the alveolar pressure will increase and the alveoli will expand and they will compress their own vessels. At the same time, the lung can expand massively sometimes and they can compress on the heart and mediastinal structures and they can cause obstruction to the blood flow. And they can produce a tamponade-like effect, minimal tamponade-like effect. That's why high PEEP is also considered as a cause of poor perfusion to the lungs. So these are the conditions that's going to increase the PaCO2, EtCO2 gradient. But still this graph is not completely complete. So I'm going to draw one more line here. So people can tell what is this line. So I'm going to shade it in a different color. I'm going to shade it in blue here. This area is referred to as anatomical dead space. Clear? So this area will be referred to as anatomical dead space, right? Anatomical dead space. We know that. And what is this area? This is the area that will be truly referred to as alveolar ventilation. This is the area that will be truly referred to as alveolar ventilation. Remember, in the alveolar dead space also ventilation is happening, but it is ineffective. The gas is just coming and going out. But this is the place where you are having effective alveolar ventilation. That is the reason CO2 is getting eliminated. Only when the CO2 gets eliminated, it's an effective alveolar ventilation. I told you already in the physiology chapter itself, the name ventilation means carbon dioxide elimination. So this is the place where you have that graph is forming. That is the place where you have an effective alveolar ventilation. Clear? So this is a very, very easy and interesting concept as well. Why I told you this graph in a very detailed way is the fact that this graph is the basis of something called Bohr equation. You know what is Bohr equation is for? It is for estimating the physiological dead space. It tells Vd by Vt. Vt is physiological dead space and Vt is the tidal volume is equal to PaCO2 minus PeCO2. PeCO2 here means expired carbon dioxide. In our modern terms, it's nothing but end-tidal carbon dioxide divided by PaCO2. If I rewrite the equation, physiological dead space will be equal to tidal volume multiplied by 1 minus PeCO2 by PaCO2. That's it. So this is the final equation. So this is the equation for a physiological dead space, right? So simple. That's all. So now your question will come, how your detector detects the carbon dioxide. So that's a very simple technique again. Let us assume this is the breathing circuit, including the lungs. And CO2 detector will be placed at the proximal portion of the circuit itself, where the gas goes in and comes out of the circuit. So it could be after the tracheal tube, it could be near the mouth itself, it doesn't matter. So this is the CO2 detector. So what does the CO2 detector detect? I mean, how does the CO2 detector detect? Very, very simple principle. Now let us assume there is a LED here. LED is light emitting diode. This is going to emit an infrared wavelength of approximately 4.3 micrometer. And this value is very important again. It emits a wavelength of 4.3 micrometer. Why it should emit a wavelength of 4.3 micrometer? Let us assume this patient is exhaling now. You know this exhaling gas will be CO2 rich most of the time. So let us assume they contain these CO2 molecules in them. So because they contain CO2 molecules in them, the light that is emitted by this LED, that is 4.3 micrometer. And why specifically 4.3 micrometer means because the carbon dioxide molecules absorb this particular wavelength. Remember, your oxygen or nitrogen will not absorb this wavelength. That is the reason why to have no interference from other gases, we emit this 4.3 micrometer wavelength, which is absorbed only by carbon dioxide molecules. So now once this wavelength is absorbed, now whatever that is left after absorption is going to reach the other end, which will be captured by a photodetector. Again, this is in accordance with the Beer-Lambert's law only, where you can easily tell if the amount of carbon dioxide in the gas column is more, absorption will be more, so the amount of light detected by the photodetector will be very less. Similarly, if the carbon dioxide in the gas column is very less, then the amount of light absorbed by the carbon dioxide molecules also will be very less. So the light that is passing through the gas column and reaching the photodetector will be more. So depending on how much amount of this wavelength, 4.3 micrometer light that is reaching the photodetector, that will be processed and sampled and be analyzed by the electronics inside the detector, and they will tell that this much amount of carbon dioxide is there. Very, very simple process. So this is how they detect the carbon dioxide. And this only one important point is that the 4.3 micrometer, you have to be remembering that for exam. That's all. So after knowing this, you also have to know what are the different types of devices available. So first one is the standard calorimetric device. So this is the standard calorimetric device. So you know that there is a mnemonic, isn't it? So this is an example. Again, this could be an exam question also, calorimetric device. So you know there is a mnemonic called BRA, which I told you, where B stands for blue litmus paper, which will turn into red litmus paper if you have a acidic pH. Acid will turn blue to red. So this is what you will learn by mnemonic called BRA. Here also we are using some kind of a blue litmus paper only, since it's detecting carbon dioxide. Carbon dioxide is like an acid, it carries protons. So it's like a volatile acid. So it's like an acid. So it has to turn to a different color. In this, it's not blue. In our calorimetric testing, it's yellow. That's all. You can see in this particular example where there is a blue colored litmus paper which is turning into yellow as soon as you connect it to the endotracheal tube. We discussed this already in detail. This capnography and this calorimetric detection of carbon dioxide is the gold standard to tell that the endotracheal tube is in the trachea and not in the esophagus. So if you see this, definitely I can tell the endotracheal tube is in the trachea only. It's not in the esophagus. Okay, this is the calorimetric method, and you can also see in the same patient, you can see nice little waveforms of carbon dioxide also. This is the capnogram. Clear? So this is one method. And next you have this kind of quantitative EtCO2 monitoring only without waveforms. This is a portable one which will be carried usually by the paramedics with them. So this is not going to show the waveforms, only going to show the EtCO2 value, right? And these are some of the other kinds of detectors as well. You can see here. So this is one kind of a detector that is in the nose, and you can see a pendant-like structure that is also detecting the carbon dioxide. These are external detectors. So a lot of types of detectors are available. You can also see that the patient is having a EtCO2 of 29, and you can see good little waveforms here also. Clear? These are the EtCO2 waveforms. So EtCO2 devices are available in multiple shapes and multiple types, but very commonly what we use is that previous calorimetric and the endotracheal tube connecting like devices. That's what I have shown. So that is what is going to be commonly used in the practice. And this is again a real-time carbon dioxide monitoring where you can see the EtCO2 curves, and here the EtCO2 is 39 in this particular patient. And this is one important image you have to know. The upper one shows the pressure waveforms in the ventilator, and the lower one shows the end-tidal carbon dioxide waveforms that is connected to the endotracheal tube. What we are showing is during inspiration. You can see during inspiration, obviously they'll be in phase 0. But during inspiration, you're getting a positive waveform in the ventilator. Obviously, inspiration is positive pressure. I mean, during physiology, inspiration is negative pressure. But in a positive pressure ventilation, when the patient is on ventilator, inspiration is positive pressure only. So you have a positive pressure during inspiration, all right. And during expiration, you can see the ventilator curve becomes flat and starts to reach the baseline during expiration, but that is the time where your EtCO2 curve will rise. So that's again a very important point. So this is EtCO2 curve. And you can see initially a small delay is also there. Clear? So this is the phase 1. So I can write this is the phase 1, this is the phase 2, and this is the phase 3. Clear? So, but it's not like as soon as the expiration starts, your EtCO2 will start immediately. There will be some minor delay will be there in EtCO2 to start in the beginning. Why? Because of the carbon dioxide should reach the detector, isn't it? Because when the patient is intubated, the carbon dioxide should come from the, or whatever the gas that you're exhaling should come from your respiratory tract, pass through the tube, and then reach the detector outside the endotracheal tube. So that passing through the endotracheal tube will take some time. So that's why there is some, maybe a little delay in the carbon dioxide and inspiratory gas detection in the endotracheal tube, in the CO2 detector. So that's again a very important curve. You can see during expiration, the pressure curves will become flat, but the E to CO2 curves will start rising. But during inspiration, the pressure curves in the ventilator will start rising, but the E to CO2 curves will start becoming flat. So it's like something like a reverse that you have to understand. And this is the CO2 detector, and this is the pulse oximeter. So is there any difference between a CO2 detector and the pulse oximeter? Answer is definitely yes. Remember, pulse oximeter detects the oxygenation, whereas CO2 detector is going to depict the ventilation. The capnogram is designed for identifying ventilation, not the oxygenation. Remember, the changes are detected immediately in the capnogram. That's a very big advantage, immediately. So for example, if the patient goes for apnea, immediate, that's all. The CO2 will become flat. There cannot be any elimination of CO2 if the patient doesn't breathe at all. But even if the patient goes for apnea, pulse oximeter will show normal saturation for at least a variable period of 2 to 5 minutes, and then only your desaturation will start. Because I told you there is something called a time to desaturation, isn't it? So it will not desaturate immediately even if you go for apnea. So it is a little delayed. So that is why both of them has to be used simultaneously, and you have to understand the strengths and weakness of both of these investigations and monitoring techniques. So my idea will be to use both so you can get much more reliable information about the patient. Clear? So these are the differences that you have to know. But next thing we are going to see about the actual waveforms. Before that, you have to understand what are the 3 things that affect the capnography or end tidal carbon dioxide levels. So for that, we can go for this particular diagram. Remember the fact that CO2 must be first produced. How the CO2 is produced? CO2 is actually produced by metabolism. CO2 is produced by metabolism first. Clear? So you need to have a good metabolism going on in the body to produce good amount of CO2. So that's the first priority. If metabolism is low, CO2 produced will be low, and metabolism I mean CO2 produced will be high. Second, the CO2 must be taken to the alveoli. So in order to go to the alveoli, in order to get to the alveoli, they should have a good perfusion. In the sense, I can write as good circulation and a good perfusion. Clearly, you have to take the CO2 from the peripheral areas or the cells, and you have to have a good perfusion to reach out to the alveoli. So circulation is very, very important to take the CO2. And next is this CO2 that is getting into the alveoli through gas exchange has to be eliminated properly. So third one is ventilation. So these are the 3 things that are needed for producing a good EtCO2 curve. So these are the basic physiology. 3 things that is needed for producing EtCO2 and the waveform capnography is metabolism, circulation and ventilation. Clear? In this, I'll tell you a simple rule. Whenever there is a change in the circulation or metabolism is happening, I can write whenever there is a change in the ventilation or metabolism happening, there will be a change in the PaCO2, there will be a change in the EtCO2 also, but these changes will be usually proportionate. Since the changes are proportionate, the gap between those two values will be usually normal, because proportionally they will change. If there is a change in the ventilation or if there is a change in the metabolism, both the values will change proportionately. So the gap will, the EtCO2 and the PaCO2 gradient will remain normal. Suppose if there is any change in the circulation, delta C, which means change in the circulation, this is like a unorthodox thing where there will be a change in the PaCO2, but the change in the EtCO2 will be too much in this condition, especially when there is a change in the circulation. So what I am trying to tell is there will be disproportionate change, which means EtCO2 decrease or change will be much higher than the PaCO2 change or decrease. So since it is a disproportionate change, your gap or gradient between PaCO2 and EtCO2 will increase. So this is what we saw already. Change in the circulation may result in increase in the gap, or especially when the circulation is reduced, means the gap between EtCO2 and PaCO2 will definitely increase. Clear? So this is the idea. So this is what you have to know. So there are three things that are affecting your EtCO2 and the waveform capnography, that is your circulation, metabolism and ventilation. Clear? So let us go on to the actual waveforms now, and I have shown the trend also. This is the first one I wanted to show. This is a normal waveform. We know that. So to understand what is a normal waveform, I have drawn here also. This is a normal waveform, and the EtCO2 must be somewhere around, as I told you, it should be 32 to 42. So that's the normal EtCO2. Here it's 37, so definitely it is normal. So, and I can also see the trend here. So the trend is maintaining in the stable baseline. There is no change, that is, there is no increase or there is no decrease. The trend is also okay. So this is the EtCO2, usual normal EtCO2 waveform. Now let us see, if you see this kind of waveforms, why I showed you, if you see this kind of waveforms, post-endotracheal intubation. Post-endotracheal intubation, if you see this kind of waveforms, it still remains the gold standard for confirming that the tube is in the trachea. I told you this point innumerable times. Fine. Then this is a graphical representation of a esophageal intubation. You can see there will be less than 6 waveforms. Initially there might be some waveforms, but there will be less than 6 waveforms, and later on it will become flat. So this is confirmatory of esophageal intubation almost, in a patient who is not having cardiac arrest obviously. So this is almost confirmatory for esophageal intubation only. You can see the trend here. There will be less than 6 waveforms will be there. Certainly they will, over a time, they will become flat. There won't be any more carbon dioxide. This initial waveforms is due to like your stomach fundic and esophageal carbon dioxide. Some amount of gas will be present, so that will be coming out. So that might produce some initial waveforms, but later on definitely no. And the next one, you can see the waveform here. So if you see the waveform, one thing that you are noting is they are decreasing serially. So they are actually decreasing. But as I told you, it will be very difficult to note unless and until you have a trend. So you can see here, I have intentionally put an image that shows a decreasing EtCO2 waveform. But in real time, it's very difficult to find out. Sometimes the changes may be very subtle. That's why we have the trend here. You can see the trend is clearly showing. These are compressed waveforms that actually the EtCO2 is decreasing over a period of time. So this is another example. So you can see this here. What I'm trying to show is the EtCO2 is actually increasing here. But this image again is an intentional depiction of that EtCO2 is increasing. But sometimes these subtle changes you may not be able to pick up. So that is why we have the trend where you can see the EtCO2 is actually gradually increasing. So now let me tell you what are the conditions that will produce this reduced EtCO2. either progressively reducing or reduced it to a small level. So what are the conditions? Number one, obviously hyperventilation. In the sense, whenever you have an increased heart rate, hyperventilation, whenever you have an increased heart rate, you are going to have a decreased EtCO2 only. Because they, obviously, like hypoventilation, you will have more CO2 elimination. Hyperventilation, you will have reduced CO2 elimination. Number two. Second, whenever you have a reduced metabolism. So there are three things that is going to affect, I told you. One is circulation, metabolism, and ventilation. So second is reduced metabolism. What are the conditions that produce reduced metabolism? I can tell hypothermia, right? Myxedema sometimes, in severe hypothyroidism. So these are some of the examples where reduced metabolism may cause reduced EtCO2. Number three, reduced circulation, or I can write conditions that produce reduced perfusion like pulmonary embolism, cardiogenic shock, cardiac arrest, or probably even we talked about that increased intraalveolar pressure causing high PEEP and very high level of positive pressure ventilation. All these things can produce reduced circulation. Because of that, you might result in low EtCO2. Clear? So remember, this low circulation causes producing low EtCO2 will definitely increase the EtCO2 and PaCO2 gradient. That value will also be increased. Fine. So what are the conditions that generally produce this kind of increased EtCO2? Increased EtCO2. What are the conditions that produce increased EtCO2? Remember, this increased EtCO2 can be produced by, obviously, hypoventilation, classically due to reduced respiratory rate. Remember, there is something called a hypopneic hypoventilation. We are not talking about that. We are typically talking about a bradypneic hypoventilation. So definitely, because of reduced respiratory rate, your amount of CO2 excreted by each breath will start increasing. Number two, hypermetabolism. What are the conditions? Fever. Clear? Number one. Number two, malignant hyperthermia. Malignant hyperthermia. Sometimes after an exercise, if you do EtCO2, obviously exercise is a condition that generates a lot of carbon dioxide and it's a hypermetabolic state. And number four, you can think about hyperthyroidism also in exceptional rare cases. But I always believe exam will be based on this only. That is your malignant hyperthermia. Very important. Malignant hyperthermia, the values may reach as high as 55, 60 and all. So you have to be careful. Intraoperatively, if you reach that 55, 60 and you have a history of succinylcholine given to the patient, you can think about malignant hyperthermia. And number three, apart from this hypermetabolism, you have increased perfusion. So when you can have increased perfusion to the lungs, especially when you are going to have a exercise. So that is one example where you can have a high perfusion. Apart from that, these are the two causes. But remember, hypoventilation causing high EtCO2 is not always the norm. Why? Because hypoventilation may result in a lot of other kind of waves also. So for example, if you see here, this is the characteristic type 1 hypoventilation that is referred to as a bradypneic hypoventilation. Bradypneic means you have a low respiratory rate. That's a type 1 hypoventilation where you can see progressively the waveforms will increase. Because of the reduced respiratory rate, the CO2 elimination per breath will increase. So that's why the EtCO2 looks as if they are increased. But there is a second type called a type 2, otherwise referred to as hypopneic hypoventilation, where the problem here is low tidal volume. Whenever there is low tidal volume means per breath how much CO2 they will eliminate will be low only because the tidal volume will be very, very low due to some neuromuscular damage. So once again, please do remember that here the respiratory rate can be normal or decreased or even increased. So respiratory rate doesn't matter here. Here the tidal volume is low. So that's why in this type of hypoventilation, type 2 hypopneic hypoventilation, the height of EtCO2 will be reduced only. So be very careful about that. And this kind of hypopneic hypoventilation can happen if the patient is on excessive sedation, like excessive ketamine. So that can also result in this hypopneic hypoventilation during a surgery or critical care. So this is the third type of hypoventilation where you can see there is a low tidal volume. That is the reason why you are having small breath. a very small EtCO2 curve baseline. And at the same time, you can see there are periods of apnea. So this is one period of apnea. And again, there are periods of regular breathing also. So which means this is a hypoventilation. Obviously, it's of hypopneic and respiratory rate is also low and bradypneic also. So totally I can tell this is a hypoventilation with periodic breathing. Remember, usually this type 1 hypoventilation and this hypoventilation with periodic breathing will be due to central cause most of the time. That is the brain cause. But this hypopneic hypoventilation, that is type 2 hypoventilation, is usually due to neuromuscular paralysis or neuromuscular weakness or excessive sedation during anesthesia. So these are some of the reasons why you get this kind of hypoventilation. Remember, hypoventilation is not just hyperventilation what you see, but in exam hypoventilation means high EtCO2, hyperventilation means low EtCO2. That's it. Fine. So now we have seen the trend also. So I showed you the trend as well already. Yeah, fine. So now the third kind of waveforms you are going to see. What you are seeing in this waveform is something very special and peculiar. You can see the height, overall amplitude remains the same. There is no much change in the overall amplitude, but you can see the baseline itself is start getting elevated. The baseline itself is start going up. So that's what you are seeing here. So this is the baseline, and you can see there is a slight increase in the baseline, and you can see the baseline goes a little up and the baseline goes even further up. And you can see that there is not much change in the total peak of end-tidal carbon dioxide in the trend value, but you can see that the baseline is getting shifted up and up and up over a period of time. In the trend also, that is clearly visible. So what does that mean? This means the patient is rebreathing. This means the patient is definitely rebreathing, no doubt about that. Rebreathing can happen due to a lot of reasons. For example, it could be due to defective expiratory valve. There is something called inspiratory valve and expiratory valve defect in the ventilator. So usually due to expiratory valve defect, this rebreathing can happen. Or carbon dioxide trap. So there is some instruments or chemicals that trap the carbon dioxide and prevent rebreathing. So if it is defective. So similarly, a lot of conditions are there that can produce this rebreathing, but overall the problem is in the circuit and in the ventilator. That's all. So you have to correct them to avoid this rebreathing in the patient. Clear? Simple. This is a rebreathing. So you can see in this again, you can see the baseline itself. Initially, this is the baseline, and over time you can see slowly the baseline itself in this waveform will start getting increased. Fine. So very, very simple. Again, this is a CO2 rebreathing. And we didn't talk about the angles. So because we need to talk about angles, because when we think about rebreathing, because in rebreathing, I will be writing there will be increase in the beta angle. What are the angles? Let us go back to the original image. So remember, this gap between the phase 2 and the phase 3, or this angle between the phase 2 and phase 3 is what we refer to as an alpha angle. And the angle between this phase 3 and phase 0, or phase 3 and phase 4, I don't like calling phase 0, phase 4, but I will tell phase 3 and phase 0, this angle difference is what we refer to as a beta angle. So what is the importance of alpha angle? Remember, alpha angle will be increased in condition that produces VQ mismatch. VQ mismatch, especially those that affecting the ventilation. Especially if the VQ mismatch, ventilation is reducing because of that, VQ ratio is becoming more than 1. Those are the conditions that will definitely increase the alpha angle. That's a very important point. And second, what are the conditions that will increase the beta angle? Simple, again rebreathing. Rebreathing is a very important condition that increases the beta angle. Clear? So that is why I told you here also. So rebreathing will increase the beta angle. Alpha angle increase in the ventilation perfusion mismatch. That is especially when VQ ratio more than 1, especially when the condition that producing low ventilation will result in increase in the alpha angle. So that's what we are going to see next. This is a next set of graph that is typically showing a particular appearance, but you can clearly note that this patient is having a increased alpha angle. You can note that. So see the alpha angle here, definitely increased, no doubt about that. And they're characteristically having one appearance. This is called a shark fin appearance. They look like shark fins. So like as if a cluster of shark is moving, isn't it? So they look like shark fins. So you can see in this particular diagram also, shark fin. So obviously, like you can see the alpha angle is dramatically increased here for sure, without a doubt. And it slowly reaches the alveolar plateau. Like the phase 2 itself is small, and to reach the end of phase 3 takes a long time. Very simple. Increase in alpha angle taking a long time during expiration means there is an obstruction. That's all. Especially small airways obstruction like COPD, bronchial asthma. Even larger airways obstruction can sometimes do that. So bronchial asthma, COPD, then bronchoconstriction, a lot of conditions can produce this kind of shark fin appearance. Very, very important for your exams. Shark fin appearance, increase alpha angle, it is obstruction. COPD, asthma, bronchoconstriction, that's all. And the trend, if you see over time, the EtCO2 will start decreasing here. That is because again obstruction will not allow the the carbon dioxide to pass as much as you like. So the CO2 will start decreasing only. Especially when the patient gets fatigue, it's going to be even more problematic. Clear? So this is the next curve. So what this curve depicts, you can see very clearly that normal curve, suddenly you are having this sudden drop in the expiratory carbon dioxide pressure. So the pressure is not sustaining. Why the pressure is not sustaining? What is the reason that the pressure is not sustaining? Can anyone tell? That is because there is some leak in the circuit. So what's happening here is the carbon dioxide is coming out. So while coming out, before reaching the sensor, it is leaking out somewhere. Probably there is a leak in the endotracheal cuff, there is leak in the tracheostomy cuff, or there leak in the ventilator per se. We don't know. Bronchopleural fistulas, we don't know. We don't have an idea. There is some leak somewhere in the apparatus. So the carbon dioxide that is coming out, even before reaching the detector, it is leaking out somewhere. So you can see here also, there is a sudden drop in the CO2 pressure and reaches the baseline. So this is suggestive of a leak. And in the trend, you can see there is a sudden drop in the CO2 pressure, but maintains at a particular level. It's not progressively decreasing like in hyperventilation. So this is definitely a leak. Clear? Okay. Then next graph, what we are seeing here will be a typical one. You can see like a cleft-like appearance. You can see something like a cleft-like appearance here in the graph. So this is a normal one. And once again, you can see a cleft-like appearance here. So this is nothing but we tend to call it as a Curare cleft. So what do you mean by Curare cleft? You can once again see that it is showing a cleft-like appearance. So when the pressure will drop, if the patient inspires, so you can see, like sudden drop in the CO2 pressure will happen when the patient starts breathing, inspiring or inhaling. So that's what is happening here. But what happens is during expiration in a ventilator, if the patient is inspiring means the patient is not getting adequate neuromuscular blockade. That's why a patient who should respect the ventilator is not respecting the ventilator, which means when the ventilator curve is going towards expiration and exhalation, the patient is taking some spontaneous breathing effects, which clearly shows the patient is having an inadequate neuromuscular blockade, which means here the idea will be to increase the level of blockade and give a more better paralysis to the patient. So this should not happen. The more deeper the cleft, worse is your neuromuscular blockade, which means your neuromuscular blockade is not effective at all. That's what it means. More deeper the cleft, more poorer your neuromuscular blockade. Clear? So it's indicating inadequate neuromuscular blockade. If they ask you next step, increase the neuromuscular blocker dosage. That's all. Make the patient into a better neuromuscular blockade portion. So you can see what is this curve. This curve is nothing. This is a flat one, isn't it? This is an absolutely flat one. This is a flat EtCO2. So what do you mean by a flat EtCO2? So when will you get a flat EtCO2? So there are some causes which can cause a flat EtCO2. I usually used to give a mnemonic called DOPES. DOPE stands for D stands for disconnection, O stands for obstruction, and P stands for patient-related causes. What are the patient-related causes? Like sudden onset pulmonary embolism, or tension pneumothorax, or it could be even a cardiac arrest, sudden cardiac arrest, or even sometimes a very big flash pulmonary edema. All these things could be the reason. E stands for equipment failure, and S stands for stacked breaths, otherwise called as breath stacking. We'll discuss more about this breath stacking, otherwise referred to as intrinsic PEEP or auto PEEP, when we are discussing about the ventilators in the next section, coming sections. But right now, remember, these are the causes for sudden, flat line in the end tidal carbon dioxide curve, or the patient has gone for apnea. Why the patient has gone for apnea? Because the patient would have entered cardiac arrest. But our interest is on the cardiac arrest only. So let us assume this patient is suffering from a cardiac arrest. Let us assume this patient is a cardiac arrest patient. Now, after cardiac arrest, if you see this kind of curves, what you will think about? Let us assume if you see this kind of curve. So this is a patient, normal patient. Okay, it's an OK curve. It's having 20, and you can see progressively decreasing EtCO2. You can see now it has become 10. It has become 10, almost. Now you see this kind of curves. Yes, almost 10 now. So I'll pause it for a while. This kind of curves, if you see, this means the patient is getting CPR and the patient is getting resuscitated. After cardiac arrest, if you see this kind of curves, means patient is getting resuscitated. And very, very, very important marker of adequate resuscitation, this EtCO2. Really, really important. In CPR, the value of this EtCO2 has been huge nowadays, because they clearly tell the most important part of a CPR. We are discussing about CPR in detail in the cardiac section, but the most important component of the CPR is the chest compressions. The quality of the chest compressions can be assessed by EtCO2, where the guidelines clearly tell to have a good quality CPR and good quality chest compressions, your EtCO2 should be at least more than 10 millimeters of mercury. So if they ask you initially when you are doing a CPR and you are monitoring the EtCO2, if the EtCO2 values are less than 10 millimeters of mercury, what you have to do? You have to try and improve your chest compression quality, or you have to try and improve your CPR quality. Very, very important point. So then again the guideline will tell, once the EtCO2 is less than 10, even after 20 minutes of effective CPR, you have tried to improve your quality, but you have tried your best for 20 minutes of CPR. Even after 20 minutes of CPR, if your EtCO2 is still less than 10 millimeters of mercury, it has not reached the 10, which means there is a poor chance that the patient will survive. They will not tell you, because this is an ethical issue, they will not tell you they can stop resuscitation, but it indicates a very, very poor prognosis that the patient might not survive. So which means EtCO2 is also a quality indicator in CPR. At the same time, it's also one of the prognostic indicators in CPR. Both are very important. One more area where EtCO2 is prognostic is in sepsis. They have clearly told patients who have EtCO2 in the range of more than 30, especially in the range of 30 to 35, has a better prognosis, whereas patients who are having EtCO2 less than 30 in a sepsis is having a poor prognosis. It's having a much bad prognosis. If EtCO2 is less than 30 in a patient who is suffering from sepsis. Clear? So EtCO2 is helpful in certain prognostic areas also. So now we are resuscitating the patient. So now you know that this curve means, the curve that I have shown here means that the patient is getting the chest compressions, resuscitation. Now you are seeing boom, something like this suddenly. What does that mean? If you see this kind of sudden increase in the EtCO2, if the patient is getting CPR, I told you at least it should be more than 10. But if you see a sudden rise in EtCO2 during a CPR like this, let me show you once again. So initially This was the CPR phase where the patient is getting CPR. You can see now there is a boom, sudden rise. Because there is a sudden rise in end-tidal carbon dioxide, I can assure that this patient has gone for return of spontaneous circulation, which means this is the end point of CPR, isn't it? So you give CPR to make the circulation return spontaneously. So that's what you call ROS. That's called return of spontaneous circulation. So this is the gold standard for confirming ROSC and stopping the CPR, which means the patient has regained the circulation, so you need not give CPR anymore. That's the idea. You can stop CPR and start the post-ROSC care. And you can try to make the patient much better by giving extra care. That is a separate entity. But this is the gold standard to stop CPR, and it's an indication of return of spontaneous circulation where the patient has regained their pulse and metabolism as such. Gold standard once again. So ETCO2 is not only the gold standard for confirming the position of endotracheal tube, ETCO2 is also the gold standard for confirming ROC as well. So these are some of the very, very, very important points in ETCO2. And I'll show you some more few of the curves of ETCO2. So this is phase 1, phase 2. So you have phase 1 here, phase 2 here, then phase 3 here. And if I take it as phase 0, I can see a bump-like appearance here. Clear? So what is this bump-like appearance? This is called a pigtail appearance or a pigtail capnogram. So if they ask you where will you see this pigtail capnogram, some books will tell you. So especially UK books will tell you, you will see additional phase 4. Because UK phase 0 means inspiration. But in some of the Western textbooks, phase 4 and phase 5 is inspiration. But depending on what book you follow, that's why I told you don't get confused. Depending on what book you study. So they call it as extra phase 4 if you think the inspiration is phase 0. If you can just call it as a pigtail capnogram if you consider the inspiration is phase 4 and phase 5. It all depends on which book you read. So pigtail capnogram. Pigtail capnogram means low alveolar complaints or the chest wall complaints. This can happen in many conditions like ARDS, pregnancy, very, very important, especially the third trimester of pregnancy. Usually in exam, this will be the cause. Whenever they tell pigtail, P stands for pregnancy. Or you can remember this as a pregnancy bump. Clear? So this pigtail capnogram. So very important question in exam. Then it can happen in restrictive lung diseases. It can happen in certain patients with other sorts of restrictive lung disease, morbid obesity. Many conditions can produce this kind of curve. Clear? This is a pigtail capnogram. Then you can see there is some sort of a ripple-like appearance in the inspiration, during the inspiration. So this is what we refer to as a ripple effect. Ripple effect. Ripple effect means during inspiration, this is an inspiration. During inhalation, you will see a ripple-like appearance in the descending limb of the curve. Why? Because during inspiration, sometimes your lungs might expand and can touch the heart. So when they touch the heart, this cardiac oscillations can cause the inspiratory limb to become oscillated like this. So which means if they ask you why you get the ripple effect, you have to answer this is a physiological phenomenon in some patients due to cardiac oscillations. Okay, so this is a staircase capnogram or staircase effect. So you can see like capnogram is like a staircase where it is due to low oxygen in the circuit. Usually due to low oxygen in the circuit, you can get this staircase kind of a capnogram. Finally, you have certain other types of capnogram also, that is called a dual capnogram. I didn't mention it, so I will tell you how will you have a dual capnogram. So you might have something like this. This is not a Currar cleft as well. So this is called a dual capnogram, where you have a double capnogram, double waveform, especially during the alveolar plateau. So this is what we refer to as a dual capnogram. So if they ask you what are the conditions where it will result in dual capnogram, many conditions can cause a dual capnogram. Condition number 1, I always expect in exam is a single lung transplantation, where the first curve is the CO2 elimination from the normal lung. Second peak you are reaching is due to CO2 elimination from the deceased lung. In a single lung transplant, only one lung will be normal, which means transplanted lung. So the other lung will be patient's own disease lung. So normal lung in the sense here I mean the transplanted lung. So the first curve will be from the normal or transplant lung or good functioning lung. Second peak will be from the diseased lung. That's the patient's native lung which has not taken out during the transplant. So this is single lung transplantation. Number 2, it can happen in patients with severe kyphoscoliosis. Number 3, it can happen in mainstem intubation, endobronchial intubation. Again, in endobronchial intubation, the first peak is from the intubated lung, endobronchial intubated lung. The other one is from the collapsed lung. So it has low compliance, so it comes late. So these are some of the causes. And you have another causes also. Like for example, you have something called a camel capnogram. Camel capnogram is a type of a dual capnogram only, where you will have this double appearance at the end of the alveolar plateau phase. So if they ask you where will you see this kind of camel capnogram, you will see in the left lateral portion, especially in the operation theaters when the operations are happening in the left lateral portion. This you can see. But if you turn this and see, it looks like an L, isn't it? So you can remember like that, its left lateral portion causes this kind of camel capnogram. Then number 5, you have this kind of dromedary sign. Dromedary sign is also like a camel hump only, but dromedary sign will be having a mid hump, not a terminal phase of the alveolar plateau. They will have a hump in the middle of the alveolar plateau. So this is what we refer to as dromedary sign. So this kind of dual capnograms can happen, this dromedary sign can happen if there is some problem in the CO2 detector device. This is indicating some problem in the CO2 detector device, where the device usually has something called a water trapping mechanism. That is a natural functioning of the device. No need to go into the engineering of the device. But still, if there is a break in that water trap, so then you might result in this kind of dromedary sign where you'll have a middle hump. So dromedary is a camel again, for your information. So these are some of the signs that are very, very important for your exams. So we have seen from low EtCO2 causes to high EtCO2 causes, how the waveform of esophageal intubation will look like, cardiac arrest, how it will look like, rebreathing, how it will look like. If you do a CPR, how it will look like. When they recover from CPR, the circulation returns, how the EtCO2 will look like. Curare clefts, how it will look like. Then obstruction, how it will look like. Then what do you mean by dopes? Then what is staircase effect? What do you mean by ripple effect? What do you mean by dual capnograms? What are the conditions that result in dual capnogram? What is camel hump, camel capnogram? What is dromedary sign? And lot of things. We have seen so many examples, and we see this pigtail capnogram also. So many conditions I have told you. All of the things which I told you are very, very important exam questions. So don't forget to miss any of these things. Take a good notes out of all these things, and definitely this is going to be a exam question according to my opinion. Thank you.